dysphagia is treated with a modified texture diet. And one of the things that adults like about food is texture. We like that crunch. We like the mouthfeel of maybe it's smooth, maybe it has a grittier texture. And so when the texture of the food is changed, and if it's different from what we're accustomed to, we tend not to eat as much. And so what we see with individuals with dysphagia and they go on a texture modified diet is they often don't eat very well. And so they're eating less food, and that means they're getting less nutrition. And so eventually it can lead to declining nutritional status. Sometimes with our texture modified foods, our animal products, our meats have a texture that people don't like. And so when that is the case, they'll tend not to eat that product. And so they may like certain things, but not others. And again, that's going to lead to malnutrition. Remember, we talked about malnutrition being related to an insufficient amount of energy intake. And when you don't have enough energy, you are using more of your lean body mass reserves. And when you take from skeletal muscle, you will take from muscles all over the body. In terms of swallowing, you have your muscles of mastication, and they're going to be the temporalis muscles as well as the masseter muscle. And when you lose the strength in those muscles, it makes it more difficult to chew and more difficult to swallow. And so being malnourished, you will lose that skill. And if the food that you are provided has a texture that's not as appealing to you, then it may be that you're still not going to get those nutrients from the food. And so remember that in high inflammatory stress, the body tends to waste more protein. So not only are we not getting enough to eat, we're not getting enough protein, we're not getting enough of the indispensable amino acids, we're losing the muscles of mastication. And so the person is in that trajectory of rapid decline. And that's how they go from the malnutrition to the sarcopenia to the dysphagia, that perfect storm that we talked about. When you look at the minimum protein requirement, the recommended dietary allowance is 0.8 grams per kilo of body weight. Now, in individuals that are going to be at risk for having dysphagia due to malnutrition, due to sarcopenia, or individuals with dysphagia, I would recommend 1 gram to 1.2 grams per kilo of body weight. Now, that's if the person is of a normal weight. If they are underweight, they may need more protein. If they have obesity, then we would need to adjust that. So it's always going to be based on individual assessment, but we want to be sure that they're getting a sufficient amount of energy as well as the protein. Because if they don't get the energy that they need, so the calories, then they're going to be using that protein for energy. But I would recommend a higher level for both older adults as well as individuals with dysphagia. Good quality protein means two things. One is that you have all of the indispensable amino acids in the protein. And some sources of protein do not contain all of the indispensable amino acids. Our vegetable sources of protein generally do not contain all of the indispensable amino acids. So that's the first thing. The second thing is you want to be sure that it has a sufficient amount of each of those indispensable amino acids. And on the slide from the presentation that the header was Protein Quality Matters, I provided you with the quality reference score pattern. that was identified by the World Health Organization as how they would define a good quality protein. Now, when you have a person who is a vegetarian, you need to be sure that you're combining your sources of protein so that you're including products that are high in all of those indispensable amino acids. So your products don't have to be from animals, but animal products tend to be complete sources of protein just in their natural form. And so you really need to look very carefully at the quality of protein, especially for our individuals with dysphagia. Well, you always want to start with looking at malnutrition and sarcopenia. Screen for that and be sure that you're not overlooking anything and not overlooking any micronutrient deficiencies. We know that diets that are high in alcohol may be low in certain vitamins and minerals. We also know that medications can interfere with absorption of nutrients or increase excretion. So you always want to look at, is the person at risk for malnutrition? Do they have any other risk factors for micronutrient deficiencies? The next thing you want to do is look at estimating energy requirements. Now, as I mentioned in the presentation, your gold standard is going to be indirect calorimetry. That technology isn't available to everyone, and so you can use the predictive equations or you can use the ranges, and those are based on indirect calorimetry, 25 to 30 calories per kilo, 30 to 35 calories per kilo of body weight. You want to look at the weight of the person. Are they within normal ranges for BMI, or do they have obesity? With obesity, again, that has to be adjusted. So these numbers are really based on, these ranges are based on individuals with normal weight. If they're underweight, those numbers may need to be higher. So always that individual assessment for both energy as well as protein. I generally go with at least 1 gram of protein per kilo of body weight. Some recommendations look at ideal weight versus actual weight. You've always got to consider the weight of the person, especially with obesity. And the other thing you want to look at is kidney status and liver status, because if those organ systems are in failure mode, so they're highly compromised, you may not be able to tolerate as much protein. But generally speaking, 1.0 to 1.2 grams per kilo is sufficient, and it doesn't stress those systems. But again, individualized assessment for kidney patients would depend on if they were on a renal replacement therapy as to what the requirement would be. If they were on dialysis, for example, the protein requirement might be a little bit higher than that. In terms of micronutrients, do we fortify with vitamins and minerals? Well, many of our products are fortified already by our food manufacturers, but in terms of adding more supplements, either an over-the-counter multivitamin or a prescription, again, only if deficiencies are suspected or confirmed. And so we don't recommend giving lots of vitamin supplements unless you can't meet those requirements with food, or there's some other reason why there's malabsorption. For example, if you've got a patient who's had a history of GI surgery and they've had part of their intestine removed, maybe it's weight loss surgery, maybe it's some other problem. If they have malabsorption of nutrients, then definitely we would want to look at vitamin mineral supplementation, but not just across the board. And then we want to be sure that the consistency is not only appropriate for the person to have safe swallowing, but that's acceptable to them. Because if the consistency is not acceptable, then they're not going to eat as well. And so our goal is to get them to consume the products that they need. I always like to use food first, but If I can't meet their nutritional goals with food, then I would go with the oral nutritional supplements. A lot of times I would use the modular, like the protein supplements, as an intermediary step, but the oral nutritional supplements certainly play a role. One of the things we've seen in the arena of wound care is that we see better healing of wounds in some of the disease-specific products. And so there's not a disease-specific product for dysphagia other than a consistency texture issue. But some of the products that are higher in protein and higher in calorie may be beneficial for these individuals. And you've always got to look at their other comorbidities that they have. But yes, I do use oral nutritional supplements and find them to be very beneficial. Do you give them with meals or between meals is always the question. Between meals is what's recommended. What you don't want for them to have is the supplement between meals and then they don't eat the meal. And so you want to space it out. But remember what we talked about getting enough leucine at a meal or at an eating time. If you're giving a lower amount of proteins and a lower amount of leucine, you're not going to initiate mTOR pathway. You're not going to start muscle protein synthesis. And so that protein will probably be used for energy. And that's not necessarily bad, but you just need to recognize how it's being used. So keep that in mind as you're recommending different products. Sometimes the oral nutritional supplement might be given in addition to something else with it that would provide that additional protein, additional leucine.